Hello, and welcome to Clearer Thinking with Spencer Greenberg, the podcast about ideas that matter. I'm Josh Castle, the producer of the podcast, and I'm so glad you've joined us today. In this episode, Spencer speaks with Gordon Guyatt about evidence-based medicine, emphasizing patient preferences and values, and better trial methods and study quality.
Gordon, welcome.
Thank you. Glad to be here.
Now, Gordon, your work has been incredibly influential in the evidence-based medicine movement, also known as EBM. But I'm wondering, how were decisions made medically about which treatments to trust before evidence-based medicine?
People did it by their clinical experience, their own clinical experience, and the referring to the clinical experience of their mentors or what people wrote in the literature about their clinical experience, and physiologic reasoning. They'd been taught physiologic reasoning as medical students and residents, and they applied that physiologic reasoning. What they didn't do is refer to the clinical literature the way we do now.
Now, I imagine with certain kinds of disorders that might work, like, okay, let's take a wart, right? You could try cutting it off. You could see, oh, the wart's gone or the wart grew back or something like that. It's very palpable and you can, see it. But I imagine for many types of disorders, that was probably quite misleading.
It turned out to be very misleading. So we have stories of, for instance, antiarrhythmic drugs after myocardial infarction, heart attacks. The people have lethal arrhythmias. They were given antiarrhythmic drugs. And eventually, fortunately, as the movement grew, we tested those in randomized trials, and it turned out they killed people rather than saving them. Another prominent example is hormone replacement therapy, where clinicians were encouraging their patients, perimenopausal women, to use hormone replacement therapy with the hopes of reducing myocardial infarction, when if anything, it increases it. So that we have many instances of benefits that we thought were there that weren't, and were even harms.
Even today, if you listen to popular podcasts that talk about health and medical issues, so many people will use biological arguments, right? They'll say, well, this drug works because it does this thing, it binds to this receptor, or they'll talk about, things in the body of cholesterol and so on. And I tend to think these are really weak arguments, that not that there's no role for these kind of biological arguments, but the problem is that, I think there's so many examples where we thought the biology worked one way, but it turns out it's super duper complicated and counterintuitive. Would you agree with me there?
You are right on, and that is absolutely right, that we think we know what's going on, and then we test it, and we found out it's not. One example is HDL, which is the good blood lipid. And we thought people with higher HDL have less heart attacks, less strokes, and die of cardiovascular disease yet less. So if you raise the HDL, it might work. So we had niacin, which raised the HDL. Well, it didn't work. Let's give a bigger dose and give it for longer. Bigger dose, get it longer, still didn't work. And then we found out about its side effects. We then have drugs called tracibs. We gave the first tracibs, increased in cardiovascular deaths. Something's wrong. We know. It raises aldosterone, a hormone in the body that can be a problem. Okay, new tracib doesn't raise the aldosterone. This has got to work. Turns out, doesn't work. So very, very often, just as you are pointing out, the physiologic reasoning makes sense, but things turn out to be more complicated than we knew.
It seems to me that the issue of confusing correlation and causation is a big factor here, that very often in medicine, we find that A is correlated with B, and that raises a hypothesis that maybe it's causal, but the problem is often it's not causal. And I think about vitamin D trials in particular. There have been so many vitamin D studies that found a correlation between health and vitamin D in all different kinds of health metrics, and that almost universally, when we go test them in carefully done randomized control trials, we find that giving people vitamin doesn't lead to the benefit. Maybe it does in a few edge cases, but it seems almost never does.
Well, the example that I just gave you of HDL very consistently In every study that has ever been done, people with higher HDL have less heart attacks, less cardiovascular morbidity. However, you have a number of agents now that raise HDL, and in one instance, it killed people. Raising the HDL with a drug does not have the same effect as the natural higher HDL. And an example of a really problematic correlation versus cause that generally raises small with people is to say, if you do a comparison of how likely people are to die in the hospital and not in the hospital, people die more in the hospital. Clearly, these hospitals are dangerous, and if we only stay away from them, we'll lengthen our lives. The obvious problem there is people in hospital are different from those who don't, and that becomes obvious to people. But in other situations, it becomes less obvious.
Yeah, that's a great example. And on that point, there's a lot of concern people have about danger being in hospitals due to getting an infection in the hospital or other kinds of issues that can happen in hospitals. I don't know how much you've looked into this, but how dangerous is it to be in the hospital, separate from the selection effects of course, more sick people end up in the hospital?
Things go wrong in hospital, and there's no doubt people have complications in the hospital. And hopefully, when one is in the hospital, one gets taken excellent care of and avoids those things. But there are no doubt there's risks that things go on in hospital. However, obviously, the situation is so don't go to a hospital if you're not sick. Don't. And if you're in the hospital and you're feeling better, get out of there. So I would certainly suggest that. But obviously, if you're really sick, there's a net benefit of being in hospitals.
Yeah, that makes a ton of sense. Now, when you started this movement of pushing for evidence-based medicine, I imagine that some people were defensive. Like if you're a physician and you've been treating things a certain way for 20 years and someone's coming in and saying, well, we need to make sure it really works. And you say, no, I know it works. I've been using it for 20 years. I could see that creating a lot of defensiveness. I'm wondering, what was that initial reaction to this movement?
Defensiveness is one word. Hostility is another. So yes, we were not subtle about it. And in retrospect, that was probably a good thing. We got the attention very quickly. But we were effectively telling people, senior people, authorities, sorry, guys, your training didn't include a certain aspect that really turns out to be quite important. And the way you've been making decisions really has its limitations. Initially, people were not thrilled to get that message, and there was a lot of hostility.
But it seems like the evidence-based medicine movement has been very successful. So how did you overcome that? Like, I imagine a lot of people wanted to shut it down.
Well, there's been some sociology studies of what was going on, but as it turned out, there was incredibly quick uptake among overall the leadership, certainly in North America. So after the landmark publication appeared in JAMA, world's leading circulation journal, in 1991, a couple of years later, I received a promotional publication from the American College of Physicians saying, in this era of evidence-based medicine, 2 years later, really extraordinary uptake by big swaths of the medical leadership. So although there was a lot of hostility in the ground, the leadership bought in a big way. So very soon, we were training people in residency programs on the principles of evidence-based medicine. Not too long before every textbook, to be credible, had to be talking about the evidence-based approach to this, that, or the other thing. So hostility on the ground, but among the leadership, at least in terms of nominal support for what we were doing, that happened very quickly. And, JAMA ran a big series right off the bat of our user's guide to the medical literature, which was picked up by all the residency programs. So there was enough positive endorsement going on so that I never felt I had to really address. I just kept doing what I was doing, right? Some of my colleagues, were pushing back against these yes, no. I didn't bother with that. I just kept doing what I was doing, and it gradually, the hostility has diminished.
And what year was that when this big paper came out and sort of as the adoption started being picked up?
1991 was the first time the term EBM appeared in the literature. That was I was the sole author of that paper, appearing in not a prominent place. In 1992, JAMA published what was the article that brought EBM to the world. So it was the one that got a lot of attention in 1992. In 1993, we started this series of articles called The User's Guide to the Medical Literature in JAMA, which then basically ended up as the curriculum for evidence-based medicine and residency programs. And the first series of articles ran between 1993 and 2000.
It's really interesting to think about how if you went to the doctor in the early 90s, you would have such a different experience than if you go now in terms of what are they actually using to make their decisions.
Yeah, so your experience might be the same. I'm not sure. I don't think we know how much physicians nowadays actually say, well, the evidence is such and such versus just, oh, I think you should do such and such. There may not be that much difference in how they present themselves unless patients start to ask about it. But what did differ is what underlies those decisions. So it is in all the authoritative information that clinicians rely on now, the evidence following EBM principles underlies every recommendation that they will find when they look for guidelines.
My understanding is that doctors now have available to them these sort of up-to-date evidence databases, essentially, so they can look up like what's the latest evidence on a given condition. Is that right?
Yes. So I am highly, highly conflicted. The resource that is most used around the world when I'm conflicted talking about this resource is one called UpToDate. So I go around the world speaking. I say how many people use UpToDate all around the world, at least in academic audiences. 2/3 of the people will put up their hand. It's an electronic textbook, was never anything other than electronic, and has this huge uptake and professes to use evidence-based principles behind everything they do. And I've been working with them for 15 years or so, and my job with them is to help them be as evidence-based as possible. So I am very conflicted about them when I talk about them, but that is one resource that I, of course, would, having worked with them for so long, endorse. They could still do better, but they're doing very well in terms of being evidence-based and extremely popular. And of course, there are other resources that guidelines. Many leading organizations have adopted principles of trustworthy guidelines, which are essentially evidence-based guidelines. So yes, clinicians can go to updated sources. One advantage of the UpToDate over traditional guidelines is new information. They get it into their recommendations within a matter of weeks.
Yeah, it seems like in the past, doctors would be trained, but then they'd have to kind of remember their training and it wouldn't be updated, right? Unless they went back and got retraining. So it's amazing that they can have the newest studies at their fingertips.
The electronic world has made things happen so much more quickly. So, well, we've also got much smoother at, when new information came along, integrating it with the previous information in what we call systematic reviews. So we produce these now very, very quickly. And then the electronic world allows it to get out to people very quickly.
And the systematic reviews essentially summarize the state of evidence on a given topic, right?
You got it exactly, and do it systematically. So we have a science of systematic reviews where we make our questions clear, we do comprehensive searches, we assess the risk of bias, we summarize the studies according to EBM principles. So it's a whole science of systematic reviews that summarize the best evidence for any particular clinical question.
You mentioned that you feel that these database systems, UpToDate being an example, but there are other ones as well, still have room for improvement. What are some of the future kinds of improvements you would see in these databases?
Well, one is just consistency. So you will find times where they slip. where the evidence has been misinterpreted, or they haven't found the most up-to-date evidence, or they were influenced, and here's one that they could do better, or they were influenced by they still have expert input, and expert input is always necessary, but the expert input, if it is influenced by experts' conflict of interest, can be a problem. So yes, use the evidence, understand it, make sure it's up to date, make sure there's the best. And when you then say, how are we going to use these evidence to produce guidelines, make sure you have unconflicted people making those decisions.
Right. And unconflicted, you mean free of conflicts of interest, essentially.
Yeah, free of conflict of interest. The most obvious is money from the pharmaceutical industry, but we at times what we call, well, non-financial conflict of interest, sometimes intellectual. We get investigators get very attached to their own work, and that attachment can be even more powerful than conflicts of interest associated with money.
Yeah, the conflicts of interest seem really important. Something I've read about is not only do medical companies sometimes control trainings for doctors, where they'll offer them trainings, which obviously has a huge conflict of interest, where they might overfocus or overpromote their own drugs, but also they send these medical sales representatives to doctors' offices and give them free drugs, things like that, but also just have, friendly people that befriend them and so on. How big a problem do you see this as being?
Okay, well, let's just be clear. We have two different issues. One issue is the people producing the guidelines for the physicians, and that's where EBM comes in. And we want those decisions to be evidence-based. Another thing is the effective marketing, where you will have one message when you go to up to date, but you have a different message with no attempt. As a matter of fact, if the marketing departments of the pharmaceutical industries were truly evidence-based, they should all be fired, because their job is to make the drug look better than it is. It's not to make it an accurate presentation, it's to make it look better. And so it's a very different issue of the efforts of the pharmaceutical industry, often successful and often with the sort of marketing strategies that you just said to make drugs look better than they actually are.
I've heard that this can come up a lot with side effects as well. Like, my understanding is that early on for SSRIs used for depression and anxiety, people viewed them as not having that high a side effect rate. But now with better evidence, we know that they actually really high rates of side effects. Like, I think sexual side effects in particular can be as high as something like 40 or 50% on some of these drugs, but that it seems like drug companies may not have been fully forthcoming with the evidence.
Well, they're not forthcoming, and you're quite right. There's a lot of stories of suppression. But the other thing is, even if they put it out in the publications, if physicians look to material from the pharmaceutical industry rather than trustworthy sources, they will find that while they may be in the publications, the emphasis on the adverse effects is hugely underplayed. So they get a very different impression than they would if they were reading the summaries and the guidelines from unconflicted folks.
To what extent are there methods, just kind of the normal social forces? If a friendly person comes in your office and smiles at you and gives you a free sample, you might kind of feel inclined to try that out with your patients, versus suppression of evidence, where they're like actually sort of hiding evidence or reporting their study results in fishy ways that make it hard to interpret.
Well, I have never seen a pharmaceutical rap, so my personal experience is zero in that, and I'm not very aware of any literature that has tried to tease out the problems that it may be there, but I don't know about it. It's trying to tease out the problem that you said about the relative influence. What you can say for sure is that the way the material is presented, as I suggested a minute or two ago, if they give a truly objective depiction in their marketing materials, then their marketing departments are doing a bad job. Their job should be within the constraints that there are some constraints put on what you can say, But if you're within those constraints, you should make the drugs look as good as possible.
Going back to the evidence-based medicine initiatives, I'm interested to know why people at the top of the food chain bothered to adopt it, right? Like, so we know that there was resistance lower down from individual doctors. I'm sure some doctors were in favor of it, but it sounds like there was quite a bit of resistance. But what was motivating the people higher up to say, yeah, we want this?
Well, here you are asking me to go well beyond my expertise and think of medical sociology or psychology or politics, which I am not at all an expert on. So I would be speculating as much as other people. There's one guy who, unfortunately, he had personal problems that never let him finish, but he was doing working on a PhD about evidence-based medicine. And his theory was that at the time that EBM came along, medicine, organized medicine was in something of a crisis. There was a credibility crisis. And EBM offered the opportunity, something new, exciting, advanced. Medicine is moving forward. That was a way of addressing that credibility crisis. I don't know if it's true or not, but that was this gentleman's theory.
Were people doubting the effectiveness of medicine at the time, to your knowledge?
Oh gosh, thinking back on it, when this gentleman was telling me his theories and so on, I thought, yeah, it sounds very plausible. I had not experienced Western medicine being in a crisis at the time, but obviously somebody who might have been more attuned to what was going on in the public perceptions might have seen that.
Whether you're a marketing manager, a product engineer, a CEO, a researcher, or a social scientist, you sometimes need to know what lots of people think about a thing, or you might want to have people enroll in a study or experiment. But recruiting study participants can be time-consuming, error-prone, and expensive. Well, good news. Positly is here to help. Positly addresses the common pain points that researchers encounter when recruiting study participants. It aims to solve common research problems and dramatically improve the speed, quality, and affordability of human subject research. With Positly, researchers, marketers, and product developers are empowered to produce better results by accessing high-quality participants through an easy-to-use web interface, making it easy to run surveys on thousands of people in mere hours, and it can now be used to recruit people in over 100 different countries. To learn more and to give your research projects superpowers, visit positly.com. That's POSITLY.com.
One thing I want to ask about is how evidence-based medicine works. And I know that the grade approach is a part of that. Can you tell us about the grade approach?
Yeah, so if you think of the evolution, so first of all, we started to do randomized trials. And then we found ways of doing randomized trials better with things like blinding, making sure we followed patients up. So we're now doing randomized trials well. We then we have a number of randomized trials addressing an issue. Now we want to summarize them. And systematic reviews we became a science of how to summarize the evidence. As I've said, comprehensive search, clear questions, assess risk of bias, and so on. And then you started having guidelines. So guidelines, formal guidelines, if you go back 40 years, they were almost non-existent. And from maybe 30 years ago, they started to get more and more prominent. And initially, the guideline movement was what we describe it as GOBSAT, good old boys sitting around a table. Well, then we came up with rules of a science of developing the guidelines. And this grade approach has to do with the science of systematic reviews and the science of guidelines. And it basically says, how do we know what's true? How do we know what evidence is high quality and what evidence is low quality? And grade is a sophisticated system that is now very widely adopted over 110 organizations worldwide in saying, how do we know what evidence is high quality and what evidence is low quality? And then we need a process of going from evidence to recommendations. And one of the ironic principles of evidence-based medicine is evidence never tells you what to do. It's evidence in the context of people's values and preferences. So GRADE is now a system of saying, how do we do these systematic reviews optimally? How do we say this is high quality evidence and low quality evidence? And what is the process of going from evidence to recommendations? And GRADE does both those things and has been extremely widely adopted.
That's really interesting about values and preferences being a key part. Could you give an example of that, how that comes into medicine?
Okay, I'll give one example. So let's say you have a atrial fibrillation abnormalities of the heartbeat, and turns out your risk of stroke goes up. And if your risk of stroke goes up a lot, then take anticoagulants, and it's a substantial reduction in the risk of stroke. But there's bleeding that goes with it, and serious bleeding. Bleeding can kill you too. And even if it doesn't kill you, it's not much fun. Big bleeding goes up substantially. So what's better? Well, if there's a big reduction in stroke, almost every patient will say, oh, the reduction in stroke is what I'll take the anticoagulants, I'll take the risk of bleeding. But for some people with atrial fibrillation, their risk only goes up a little bit. And so the magnitude of effect when you take any anticoagulants is only a small reduction in stroke. Under those circumstances, some people will say, I'll accept the bleed, even though it's only a small reduction in stroke, I'll accept that increase in bleeding. Other patients will say, no, thank you. Why should I take this drug when it's going to increase my bleeding when I'm only going to get a small benefit? So there's one trade-off. I'll tell one more story. Periodically, I'm a specialist in internal medicine, but I'm asked to talk to other audiences like pediatricians, and I have to come up with a pediatric example. And the pediatric example that I come up with is that I use often is antibiotics for middle ear infections. Well, as it turns out, antibiotics for middle ear infections, you get a small reduction or a small increase, in another way of looking at it, a small increase in how quickly the kids get better from the pain in their ear, in a proportion of the kids. But some of the kids have the antibiotics give the kids diarrhea and GI upset and rashes. And so what's better? Pain gets better in a day or two early, or the risk of the diarrhea and rashes? And when I present to audiences, I tell them at the beginning, okay, what do you think about this taking antibiotics? And then I give them the evidence, and then I say, okay, who thinks now the kids should get antibiotics? And some people put up their hands, and some say, who thinks they shouldn't? And some people put up their hands because it's how they weigh the benefits and the downside. And then some people don't put up their hands. And I say, only those of you who didn't put up your hands have actually grasped the principles of evidence-based medicine, which is, it isn't our choice, folks. It's the patient's choice, and in this case, the parent's choice with their kid. Some will say, yes, kids screaming, anything that'll make the pain better quickly, I want it, I'll take the risk. Others, that isn't bothering the kid too much. Diarrhea, rash, no thank you. So those are a couple of situations, one from adult, more serious medicine, one from very common kids problem, that illustrate that evidence doesn't tell you what to do. It's evidence in the context of people's values and preferences, which means that clinicians need to attend to patients' values and preferences.
It seems to me that this comes up a lot and is even more amplified in end-of-life care, where some people are going to say, yeah, give me every single thing you can to keep me alive. And other people are going to say, you know what, if I'm suffering, I don't want to be alive. And if I don't have a good prognosis, I'd rather not be here.
You're absolutely right. That's another extremely vivid example where values and preferences differ. The evidence can be that we have some where it's a 3 months gain in lifespan at the cost of increased suffering. And very reasonable decisions to say, okay, yes, I want those extra 3 months. I'll suffer a bit, but I want it versus no thanks, not for me.
In my own life, I feel that I've had some doctors that seem to handle this values and preferences bit really well, and others that didn't handle it well, where sometimes you go to the doctor and they just say, okay, take this medicine, and you don't really feel like they've given you enough information to understand the trade-offs you're making. Whereas other doctors say, well, I could give you this, but here's the downside. If they give you this, you could have this side effect, and you have to trade that off against, how much you care about the condition and so on.
No, you're absolutely right. There are, from an EBM point of view, there are better doctors and not so good doctors. And if you're in a fee-for-service schedule and your goal is to get the patient out of the office as quickly as possible, maybe you just tell them, oh, this is what you should do. Thank you very much. See you later. Where others will be what we would consider more responsible and take the time to have what we call shared decision-making, which the goal of which is to ensure that the decisions are consistent with patient values and preferences.
I feel that to some degree this cuts against doctors as authorities, because obviously they're authorities on the medicine, but in my experience, they often communicate in a very kind of confident way, like, you have this problem, take this medicine. And it seems to me they must be trained to do that because it's just so ubiquitous that doctors can communicate in this confident way. Maybe it's because it makes greater compliance, but it seems to me that it does present a problem when you really have to put things back in the patient's hands and say, well, what do you actually want? What do you care about?
Well, our line in EPM is, we are the experts in the evidence. The patient is the experts in their values and preferences. And I think you're right about training, that emphasis on training people to do shared decision-making is something that we could be doing a lot better. And training people in that way would deal to some extent with the problems that you've correctly identified.
I love that phrase, the way that you said that. I think that's so perfect to encapsulate the concept. Tell us a little bit more about grade. So what is grade actually producing, and sort of what are some of the factors that go into it to decide the quality of evidence?
Okay, so let's remember, grade has these two aspects: quality of evidence and then going from evidence to recommendations. But you ask about the quality. So to put it very simply, randomized trials start as high quality evidence in grades categorization of high, moderate, low, and very low. Non-randomized studies start as low quality evidence.
Maybe you could just tell the audience, why is that? What's so special about randomization?
So I'll use two examples to illustrate it. I'll come back and say, okay, I do a study and I find out that people die more often in the hospital. And I conclude hospitals are dangerous places. If we only stay away, we'll be much better off. Obviously, everybody thinks it's ridiculous because they say, but the people in hospital are much sicker. On the other hand, as soon as you move away from that extreme example, it becomes not so obvious. So, for example, it turns out that there was good biological reasons why antioxidant vitamins should reduce cancer and cardiovascular disease. And large observational studies, non-randomized studies, demonstrated that people who took antioxidant vitamins had appreciably lower cardiovascular risk and appreciably lower cancer risk.
So that's just looking at surveys and saying, are you taking this vitamin or not? And then correlating that with health.
Or is your diet high in the antioxidants? That's right. And the people whose diet was high in antioxidants who were taking vitamins, they had less cardiovascular disease and less cancer. It was true. The people who took the vitamins did have lower cardiovascular risk and did have lower cancer. Unfortunately, it had nothing to do with the antioxidant vitamins. As it turns out, when the randomized trials were done, no benefit at all with either cancer or cardiovascular risk from the antioxidant vitamins. So it's like being in the hospital. The people in the hospital are different from the people who are not in the hospital. The people who take antioxidant vitamins are different from the people who don't take antioxidant vitamins. And any non-randomized study is plagued by this bias, which we call confounding, which simply means the people who are exposed to the intervention are different from the people who are not exposed to the intervention. And if the intervention appears beneficial, it may not be the intervention at all. It may be the differences in the people who use it and the people who don't use it. So that is the essential reason why randomized trials start as high in our hierarchy and non-randomized or observational studies start as low. But saying all randomized trials are wonderful would be very naive. And as it turns out, what GRADE does is we've identified 5 categories of problems. Risk of bias. Randomized trials may not be done well. People may mess up in the design, and that's a problem. The results may be inconsistent from study to study, and sometimes we don't know why, and that lowers our certainty. The sample size of the studies may be very small, wide confidence intervals. We say that the truth could be very different with a small sample size. We really do not have precise estimates. That could be a reason for rating down. Or the patients could be very different. I've worked as a general internist, a hospital-based general internist. I deal with a lot of people over the age of 90. Well, I try to base my practice on randomized trials. Do they really apply to those patients over 90? Very few, if any, who would have been in randomized trials. Maybe not. I'm not so sure. And finally, we worry about publication bias. So although randomized trials start out as high certainty evidence, problems in any of those 5 categories may lower the certainty of the evidence. On the other hand, although observational studies start as low certainty and they can go to very low if they have the same problems, on occasion, observational studies, non-randomized studies, can yield high certainty evidence. When does that happen? It happens when we have huge treatment effects. So if you think of dialysis in people who have terminal renal failure, if you think of epinephrine and anaphylactic shock, if you think of insulin and diabetic ketoacidosis, if you think of hip replacements, these are all situations when appropriately we never did randomized trials. Why not? Because the effects were quick enough and large enough that you didn't need randomized trials. It was obvious that these treatments were beneficial. So occasionally observational studies, when there's a very large effect, they can end up with high certainty evidence. So it's a much more sophisticated system. Randomized trials start high, observational studies start low, but a very careful accounting of the things that can lower the quality from the randomized trials and particularly large effects that can raise the quality of the evidence from observational studies. So that's basically in terms of deciding on the quality of the evidence, how the system works.
I think about that point about effect size, that if you have a really, really strong effect, you kind of don't need as sort of those same rigorous controls. And, to use a really extreme example, imagine someone claims they have an invisibility potion. If they drink it, they'll turn invisible, right? And then they drink it and they turn invisible right in front of your eyes. Well, obviously your first thought is, okay, maybe they're doing trickery, they've got mirrors, they're a magician. But if you can rule that out, like you only have to turn invisible a couple of times to be, okay, that really works, right? Like the effect being so unlikely to occur if the treatment's not working, it sort of allows you to kind of get around some of these requirements. Yeah.
I'll tell you the most extreme, resuscitation after cardiac arrest. It used to be that when your heart stopped, you were dead, and that was the end of the matter. 0 survival. Now we have a resuscitation procedure. Most people still die, mind you, but a few of the people get through who obviously would have been dead. So there's an example where you're 100% sure that if you just left the patient alone, they're dead. You go through a resuscitation procedure, some come back to life. People also use the example of jumping out of a plane with or without a parachute as another example that people use. Another one I say, when someday somebody gives somebody a pill after an amputation and their limb grows back, we will not need randomized trials.
I love that. Yeah, it's a great example. I feel that this issue of study quality is so important and is so misunderstood because there seem to be a lot of people that have come to sort of be distrustful of science. And I think part of that is they see all of these studies claiming all of these things, and then later there's a study claiming the opposite, and you can kind of cherry pick to kind of prove whatever you want using studies. And I think the missing piece there is study quality. If you think of studies as just one kind of thing, then yeah, it's totally baffling. Why are there studies saying X and also not X at the same time? There's a wonderful graph it's like everything has been proven to cause cancer and cure cancer. And it shows all these different studies showing that like coffee causes cancer and cures cancer. Bananas cause cancer and cure cancer, right? But once you realize that, wait, many, many studies are low quality. If you don't get them out of the system, then you're just going to be overwhelmed with noise and garbage, right? If you really focus on the high quality studies though, yes, occasionally studies will contradict each other, but much less often. And when they do contradict, it's often for much more explainable reasons, like the populations under study were much more different from each other.
Well, everything you said is absolutely right, except the more explainable. As it turns out, the observational, the non-randomized trials, their failures are easily explainable for the reasons that I suggested. The people exposed to the intervention, the treatment, the exposure are different from the people who weren't. And in fact, we know that happens. We know in advance that it happens. So if we're smart, we may, if all we have is the observational studies and we don't have randomized trials, we have to rely on them. So at one stage, it made sense to take antioxidant vitamins. Oh, it looks like they may reduce cancer and heart disease. But people understand the situation. They might say, I'm not going to bother with the antioxidant vitamins until we really find out whether they work. And those persons who waited would have saved themselves some money and actually some side effects from antioxidant vitamins when we found out. So the point is to know advance. I'll give you an example. Now there is a big fuss about alcohol is bad. There have been a lot of studies of alcohol for years, but now authorities have said, oh, stop drinking. We do not know the adverse effects of alcohol because nobody has done randomized trials and followed up to see the effects of alcohol. And the inferences being made are much too strong. And it's not mysterious. They are much too strong because of this problem. People who drink more, people who drink less are different from the people who are different from one another. And it may be that if there are differences in outcomes, which are minor, actually, and inconsistent in the results across the studies, it may be those things, if there is any effect at all, that those are responsible. So we actually do know the problems with these, what you call low quality. In randomized trials can be low quality if they mess up in implementing them too. But in general, we know in advance. We know that there's lower quality evidence from these observational studies, and that's the way it is. If it's all we've got, well, we should pay some attention to them, but with a healthy dose of skepticism.
Fair point. And on the alcohol consideration in particular, I think we probably do have a lot of evidence that really high levels of alcohol are terrible for you. Would you agree with that?
So you're absolutely right. You're an alcoholic. It's bad news with terrible effects on your health. No question. But moderate drinking, no. It is, I would characterize the evidence as low quality. And maybe cutting out completely would have good health effects. I'm quite skeptical.
It's such an interesting example because it's been in the news for I feel like 20 years the news has been running headlines about alcohol. There was some evidence that was observational that, it's actually having one drink is actually better than having 0 drinks.
That's right. So the evidence has evolved and the evidence has moved more toward a suggestion of possible harm, but hugely overplayed from my point of view.
Clearly, we need to randomize people to have alcohol, right?
Yeah. And unless you could do something where people would agree to say, okay, I'll teetotal for the next whatever time period, or I will be my usual moderate drinker, we're never going to know for sure. And that's one of the things. People don't like it. If you say, sorry, we're never going to know for sure, which is, I think, the case here, because I don't think those randomized trials are feasible. So we're never going to know for sure. So we have to live with uncertainty. That makes some people uncomfortable. And that's one of the things that EBM accepts. Okay. Many situations, we're never going to have better than low quality evidence. We're never going to be sure.
Yeah. And that's really tough as a patient, right? If you have some serious problem. And all the evidence is low quality, you're kind of, you're fishing in the dark a little bit. You just kind of have to try things.
Well, what you have to do is to say, here, the clinician will say, here's our best guess of the benefits. We're not sure. Here are our best guess of the downsides. We're not sure. And then you have the decisions under uncertainty. And some people will be risk averse and some people will not be risk averse. So it's like the decisions we were talking about before, where you're trading off thrombosis or bleeding, where you're trading off quantity or quality of life, or you're trading off the duration of the kid's pain versus the diarrhea and the rashes. But what we're talking about now is adding an additional component that makes that decision more difficult, which is, well, we're not so sure about the bleeding or the stroke reduction. We're not so sure about the duration of the pain or how often the diarrhea or the rashes will occur. So that uncertainty adds an additional challenge to the decision making.
Right. It's like decisions are hard enough when they trade values against each other, when you know what you're trading off. But now it's like probabilistic. You're probabilistically trading off values.
Yeah, it makes it more difficult. Makes it more difficult for the physician and for the patient. But that's what we're facing, and we definitely think it's much better to acknowledge the uncertainty than to pretend we know when we don't.
Have you ever found yourself struggling to remember an interesting takeaway from a podcast you listened to last month? Have you ever considered how much valuable information you've consumed and then forgotten in the past year? We tend to think we've learned something as soon as we've seen it once, but the harsh truth is that we forget pretty much everything unless we use it repeatedly. ThoughtSaver is a free tool that was created to solve this exact problem. Every day, ThoughtSaver emails you a quick flashcard quiz designed to help you remember the things you care about. If you're not sure where to start, ThoughtSaver has some ready-made decks of flashcards across a wide range of topics that can get you started learning many interesting and important concepts. Or if you've already got ideas in mind, you can dive right in and start making your own decks of cards. Start using this powerful free tool and begin strengthening your recall of important ideas. Head to thoughtsaver.com.
Do you think that we have too many low quality studies and it'd be better if those resources were spent on a smaller number of high quality studies? Because obviously high quality studies are often more expensive, sometimes way more expensive. But it seems to me that there's a certain bar below which a study is like, it's not even useful. It's so low quality. And I don't know about you, but I see a lot of studies I think don't meet that bar, where I'm like, I would have rather the study not even be run because the money would be much better used on higher quality stuff.
Absolutely right. The COVID pandemic was a great example. We had many crummy randomized trials, hundreds of them, I don't know, thousands of them. And then we made huge advances very quickly. We got 3 drugs that are known to have clear benefits in non-severe COVID and another 3 classes of drugs in severe COVID. We did the randomized trials very quickly and got answers, which was great. But that was a small number of large, high-quality studies, when huge waste on hundreds, literally hundreds, of crummy little studies that did not help.
They probably made things worse because people read all kinds of things into these. They created conspiracy theories.
You're absolutely right. One example, ivermectin. The early studies suggest possible benefits. Crummy studies, when better, larger studies were done, no benefit.
Unfortunately, some people, by the time the early studies were done, they'd already convinced themselves that ivermectin was this incredible wonder drug. And then they couldn't psychologically back out once the better studies showed it didn't work. Yeah.
People find it hard to go back. You're absolutely right.
It's a sad state of affairs. And with the, I don't know how much you've looked at this in particular, but obviously people have a lot of concern about the vaccines. I mean, the effect sizes on the vaccines are pretty incredible from my point of view, if you look at the studies on the effectiveness of the vaccines. But people had a lot of concern about negative side effects. Did you look into that issue in particular?
No, I'm familiar with it in the sense that the benefits of the vaccines for anybody at high risk is absolutely clearly overwhelms any possible harms that people will experience. And people in values and preferences may say, oh, I put a much higher value on avoiding the harms than getting the benefits. But if they understood that the benefits are lowering their death rate and to a substantial extent, and the harms are very, very rare, it'd be hard to think of a rational person declining a vaccine once they know that.
I guess matters get a bit more complicated when you're not talking about, an 80-year-old with chronic health conditions, but you're talking about, an 18-year-old who's perfectly healthy. And then, the chance that the COVID vaccine really, saves their life is really very, very small.
Absolutely right. So a huge issue that evidence-based medicine makes a big fuss about is, what is your baseline risk? If your baseline risk of something is very, very low, then the benefit you can get is going to be very, very small. And so absolutely, that's why appropriately public health officials tell that if you're over 65, time to get your vaccines. They will not push it at younger people. Why? Because the risk of bad things happening is so much greater in the older folks. So absolutely, a rational approach to this, if it's very unlikely that bad things are going to happen to you, don't bother with the testing. Don't bother with the vaccination, and don't bother with the screening tests. Generally, our screening tests, breast cancer screening in particular, colon cancer screening, they are oversold to people with low risk.
Yeah, that's a really interesting point, because false positives are such an issue, right? If you have a low base rate of having a disease and you go test yourself for it, and you then spread that across society, you're going to find tons and tons of people that apparently have the disease but don't really.
That's absolutely right. And there are epidemics being created when we are defining the disease. So epidemic is in part real, but in part it's because of changing thresholds of what we call diabetic, particularly diabetes in pregnancy. We create disease by setting, because it's quite arbitrary. Okay, shall we call diabetes when your blood sugar, your hemoglobin, and A1C is at level A or B? Well, you lower the threshold where you're going to call it diabetes, suddenly you have a lot more diabetes.
That's really interesting. But if you hold it constant, the definition, surely it has gone up a lot with the rise in obesity, I assume?
Yeah, it's very, in type 2 diabetes, which is the ones you get in adulthood, has definitely gone up as a result of lifestyle issues. We have an obesity epidemic. It's very related to obesity. So yes, holding that constant, it has gone up for those reasons.
The obesity issue I find to be so interesting, because I think there's a lot of prejudice towards obese people, which I think is extremely unfortunate. At the same time, as far as my reading of the evidence, losing weight when you're obese really can have dramatically positive health effects. And so there's this interesting tension where there's people who want to resist the health evidence, saying, no, it's fine to be any weight. You should love yourself at any size and so on. But at the same time, I think, unfortunately, it is really linked to negative health outcomes.
I will use your alcohol analogy which I think applies here. If you're very obese, that's a huge health problem. If you're modestly obese, not so sure. So for the very obese, unequivocal issue. For the modestly obese, maybe not so sure.
Although my understanding is that with diabetic patients, putting them on diets where they lose a modest amount of weight seems to have caused significant improvements, if I understand the evidence properly.
You understand the evidence very well, and it causes their hemoglobin A1C or their blood glucose to go down. Does that translate into less strokes or less cardiovascular disease or less blindness or less kidney problems? That hasn't been shown yet. Quite possibly, until once again, we're relying on biologic reasoning, right? Okay, bring down. And in terms of biologic reasoning, we have a whole bunch of drugs that lowered blood glucose and did nothing for stroke or heart attacks or cardiovascular death or kidney problems. Nothing. Lowered the blood glucose really well. The last few years, we've had a couple of drugs that come along, one of which has trivial effects on blood glucose, and it lowers your heart failure and your cardiovascular deaths and your total mortality. A total disconnect between the extent to which your blood sugar is lowered and the prevention of what you really want to prevent, which is the long-term morbidity and mortality. So again, you cannot be so sure. So yes, you're absolutely right. For some people with diabetes, that particular condition, that losing weight will bring your blood sugar down. Yes, maybe a good chance over the long term that'll prevent the complications. We don't know for sure. Outside of the diabetes situation, it becomes even more questionable about being modestly obese and losing weight will actually have long-term health benefits.
Well, you touched on such an interesting issue, which is this, I don't know what the technical term for them, but essentially proxy variables or intermediate variables.
We call them surrogates, surrogate outcomes, surrogate or substitute outcomes.
Right, because it would be awesome if you could, for every study, track people for 10 or 20 years and see how many of them die, right? And see what the effects on mortality are or other outcomes that we kind of intrinsically care about, right? Effects on heart attacks, et cetera. But the reality is that's an insanely expensive thing to do. And also because those things are really rare, you would need an absolutely massive number of participants in your study to get enough people getting heart attacks or dying to measure those outcomes. So, it's super appealing to say, well, let's just use a surrogate variable that we are pretty sure predicts heart attacks or predicts mortality so that we don't need to track an insanely large number of people for an insanely long amount of time. But then it raises all these issues. Well, okay, but how good is that surrogate? Are we sure that changing the surrogate variable really will lead to a difference in the outcomes we care about?
And the answer is over and over and over again, no. And we have the examples. Now, one thing you said there, I point out, you said, well, if your risk is really low, then you would need thousands and thousands of people to find out. But as you pointed out earlier, if your risk is really low, your possible benefit is really small. Maybe it isn't worth it anyway under those circumstances. And when your risk gets higher, it would be nice, but over and over again. I gave the HDL example. We were sure people with high HDL have lower cardiovascular risk. No doubt, demonstrated over and over again. We have this, I described a whole series of studies where we had drugs that raised the HDL and over again did not do anything for your cardiovascular risk. And we have many, many examples of failure of surrogates. So from the EBM and the demonstration of an effect on the surrogate is low quality evidence about any impact on the patient-important outcomes.
What are the best surrogates that we have that we're really confident that changing the surrogate variable will lead to a difference in outcomes?
There are very few. Viral load in HIV. Every time, different drugs, every time we substantially lower viral load, the mortality goes down. That's the only one that I feel really confident about.
Wow, that's a sad state of affairs that there aren't more, because they would be so incredibly useful if we had really good surrogates, because we could then just study the effects of drugs on the surrogates and, come to conclusions so much faster.
You are absolutely right. Sadly, we don't.
Another issue that we touched on very briefly, but I think it's worth addressing, is the idea of absolute risk versus relative risk. It's so common that the media will report on some finding and saying, this triples your rate of such and such cancer, and it sounds so scary, but then you learn, okay, wait, the cancer, there's like a 1 in 100,000 chance or 1 in a million chance you get that cancer. So, what is tripling the rate? Okay, from 1 in a million to 1 in 3 million? Well, it's almost certainly not going to kill you. So almost certainly tripling that rate is irrelevant to your life.
And when it's those low rates, the only studies that could have been done to substantiate that in the first place would be observational studies, which are low quality to start with. So you've got low quality studies showing trivial effects. And indeed, a fundamental principle of evidence-based medicine is relative risks are fundamentally unhelpful in making decisions. Another example I'll give you, you get a 50% relative risk reduction in mortality from a drug. Oh man, cutting your risk of dying in half, that sounds good. However, if your risk is only 1% and using the drug takes you to 0.5% and there's lots of side effects, absolute risk reduction, 1 in 200, lots of side effects, maybe not. The same 50% relative risk reduction going from a 40% risk of dying to a 20% risk with an absolute reduction of 20%, it's a clear winner. So that 50% relative risk reduction sounds good either way. In one instance, it's trivial. In another instance, very important. So you've hit again on one of a fundamental principle of evidence-based medicine. Relative effects are actually by themselves basically useless unless you know the baseline risk and know that the magnitude of the harm, if we're talking about an increase, or the magnitude of the benefit, if you're talking about a decrease, is substantial because of a substantial baseline risk. And if it's trivial, no thank you.
It's so easy to get the two of them confused as well. I mean, relative risk, you're saying a percent reduction, and absolute risk, you're saying a percentage points reduction, right?
Well, it's both percents. The issue is it's an increase from what it was before in terms of twice as much, 3 times as much, or half as much, or a quarter as much. And try to think, people have it's good when people use about shopping. Okay, 20% off on a particular item. Well, if the item only costs $1, you've saved 20 cents. 20% off another item costs $1,000, you've saved yourself $200. So it's that would be an analogy that might be helpful for people.
Now, shifting topics a little bit, before we wrap up, I wanted to ask you about some specific areas where evidence-based medicine might play a role. And one of them is the DSM, the Diagnostic and Statistical Manual for Mental Disorders. As I understand it, when the DSM was first developed, it was very much developed by a committee, a bunch of professionals kind of getting together and people advocating for their favorite mental disorder to try to get it in there. And over time, I think they've at least been somewhat more evidence-based, but I don't know to what extent they have been. So what are your thoughts on that?
My thoughts are, I don't know much. I am not a psychiatrist, and I think it's still a committee. And one thing I would point out is inevitably these things are very, very value and preference laden. So what is a disease? There was a time when homosexuality was a disease. In the DSM, at one time, it was a disease. It's fortunately no longer a disease. Is alcohol use disorder a disease? Is drug use disorder a disease? You think of it as a disease, you treat it differently than if you consider it a failure of discipline on the part of individuals who have the problem. So aside from the evidence, there's a lot of value judgments going on in the whole notion of psychiatric illness. So I think psychiatry is moving in the right direction, but still not great.
Another area where this has come up recently in the news is with Alzheimer's treatments, and in particular the amyloid hypothesis, that amyloids in the brain basically build up, and then this is sort of intrinsically linked to getting Alzheimer's, and then if you can clear these amyloids out, maybe people will recover. And obviously Alzheimer's is incredibly serious disease affecting huge numbers of people, so it's a really big deal. But a lot of this evidence has now been called into question, or some people are arguing, well, maybe it's just correlational, like maybe if you remove the amyloids, it doesn't actually cause much improvement in outcomes.
The reduction in amyloid is a surrogate, right? Okay. People with Alzheimer's have more amyloid. Therefore, we get rid of the amyloid, it's going to help. Sorry, not necessarily. And as far as I can see, none of the anti-Alzheimer's drugs have any sort of impressive effect.
It's so sad because it's such a serious condition.
No, it's horrible. It is. My dad died of Alzheimer's. Horrible. It was horrible.
And it almost makes you angry at the low quality of evidence and something so serious. You're like, come on, we need to get our act together and use high quality evidence. We're talking about people's lives.
Well, it's not low quality evidence, actually. for most of the drugs, it's high quality evidence that they do little or nothing.
Okay, fair.
Right? It's quite different.
Well, it's more about I guess the scientific process kind of failed us.
We haven't got the drugs that work. It's not that we haven't tested them. We've tested them and we find out they're more or less useless. We just haven't come up with the medical breakthrough of something that would work. And the diabetes example, from the discovery of insulin way back in the 20s till very recently, we had lots of things that lowered your blood sugar, but nothing that lowered your cardiovascular risk. And finally, only in the last decade have we, and even less in terms of the uptake, have we finally got something that if diabetics take it, they actually improve their long-term outcomes.
And what is that drug?
Two major ones are, I can tell you the classes of the drugs, and there's multiple ones in each. SGLT2 inhibitors is one class of drugs, and GLP-1 agonists is a second class. We now have these two classes of drugs that lower cardiovascular and renal risk. And as I said, for one of them, the GLP-1s are similar blood sugar reductions to other anti-diabetic drugs that have no benefits. The SGLT2 inhibitors have less glucose lowering properties, but the others don't have benefit to cardiovascular risk, and the SGLT2 inhibitors do.
And the GLP-1s, that's isn't that the class of drugs that Ozempic and the other kind of anti-obesity drugs are?
The other thing about the GLP-1s is they have some of them, and it varies across the drugs, have these incredible weight loss, aside from the diabetes stuff and the long-term complications in diabetes. They have these amazing weight loss properties. So again, these are discoveries. Evidence-based medicine can tell you whether it works or doesn't. It's something that happens before the evidence-based process in the labs or whatever, where you come up with the treatments that evidence-based medicine can then tell you whether they work or not.
Another question I wonder about for evidence-based medicine is how our understanding of placebo has evolved.
I don't know how much it has evolved. We know placebo effects exist. We know that there are bigger placebo effects in some things. So injections have bigger placebo effects than pills. Surgery has very nice placebo effects. So there's been refinement, but the fundamental nature of the placebo phenomena we've known about for a long time.
Some people have questioned the efficacy of placebos. In fact, I'm going to do a whole episode about this in the future. And I think the main argument there is that a lot of what is called the placebo effect is not really a placebo effect, because if you have a randomized control trial, you've got your intervention group, you've got your placebo group, and the placebo group is receiving sugar pill or some other placebo. But a lot of the improvement you see in the placebo group is not necessarily due to the placebo effect. There are all these other effects that could lead to an improvement in the placebo group, like regression to the mean and other effects. And so people kind of suggest that maybe the placebo effect is a lot weaker than a lot of people realize.
You may know something I don't. I know there's controversy and back and forth, but sometimes there's big placebo effects, sometimes there aren't. I was just involved in studies of a drug for chronic cough. Absolutely gigantic placebo effects, unequivocal gigantic placebo effects.
But how do you know it's a placebo rather than, say, like reversion to the mean or some other effect?
Well, excellent point, because in observational studies, so let's say what regression to the mean, people come to you when they're at their sickest, and so that you get them at their sickest, and so you anticipate, in the ups and downs of the disease, if you get them at their sickest, they're going to get better. That's just over time, that's the regression to the mean. But we have observational studies of these people with chronic cough, and they stay stable over long periods of time.
Okay.
You put them in a randomized trial, and man, whether they got the drug or whether they got the placebo, their coughs get much better. These huge, really quite astounding improvements just from placebo effects. So it created a problem for the makers of the company who do that. And so one solution to that is to start giving them the placebo, let them have their placebo effects, and when they stabilize with their new level after the placebo, then randomize them to continue in the placebo or the new drug. Anyway, he created because the placebo effect swamped any possible. It absolutely was much bigger than any effect of the drug. So I'm sure there are situations where there's a minimal placebo effect, but it's clear there's variability. It depends on condition to condition.
Mm-hmm, mm-hmm. Right. And if you're studying something like a cold, which is naturally healing or for the vast majority of people, if you give them nothing, they're of course going to feel better regardless of whether there's a placebo effect. So you've got to be careful. But as you point out, if it's a chronic condition that we know doesn't tend to improve on its own, that makes it a stronger case for there being a real placebo.
Oh yeah. Oh, for sure. For sure. And too bad, I'll tell you, this chronic cough can be really miserable for people. And unfortunately, once you've had it for a while, it tends to hang around.
So the final thing I want to ask you about is the future of evidence-based medicine. What are the sort of initiatives happening now? Where do you see the biggest room for improvement in what we're doing?
Well, one thing is we've talked about shared decision making. You've mentioned the doctors who don't really do very much in shared decision making. We need to train our clinicians to do shared decision making, and we need to make it more efficient. We need better what we call decision aids that help the patient and the physician in the clinical encounter to efficiently understand the evidence and so make appropriate shared decision making. So that's one thing. Another thing is that during COVID, we had a big investment in randomized trials. So two things about it. Number one, there's a tremendous waste of these crummy little randomized trials. We need to concentrate our resources in doing the big, well-done trials that yield results and that really tell us something. And the COVID epidemic, we did very well. Whether we could keep that up and extend it is a much bigger question. Another thing within the public health end, and what you alluded to this, is that we cannot pretend that we know what's going on when we don't know what's going on. And so that, as you pointed out, disillusions people. They see everything's changing. What's going on here? Well, if we said in the first place, sorry, we don't know what's going on here with the masks and the other personal protective equipment, at the beginning, we didn't know at all. And we're still not sure. We are still not sure about how much good those masks do. But that's not the messages that were given out. I think we made a big mistake taking the kids out of school. And again, if we had acknowledged the uncertainty and the downsides, maybe we wouldn't have made those decisions. So another area where we can get a lot better is in our presentations, acknowledging the uncertainty when there's a lot of uncertainty there.
It seems that authorities feel like it's better to state something confidently, even if they're unconfident, than to express the uncertainty. And I feel like that was just disastrous with COVID. Like, they would tell us things and then with confidence, and then the thing would be wrong, and it would completely erode people's trust.
I could not agree with you more, and that's the point I was making. I could not agree with you more. That is, when we are uncertain, we need to acknowledge that we're certain. And you alluded to the fact that people might not like that. People might be uncomfortable with uncertainty. But man, the strategy of dealing with that discomfort by pretending you know when you don't know, that is a mistake.
Well, Gordon, thank you so much for coming on. I really love this discussion. And I just want to say, I don't know how much you think about this because your work is very indirect, but you've probably saved an absolutely massive number of people's lives through your work. And so I just want to thank you on behalf of society.
Well, that's very kind of you. Yes, my effects are indirect as far as that's concerned, but I'd like to think that the work has had the impact that you're suggesting. So thank you very much.
Thanks again for listening. We always love to hear from our listeners, so if you have questions or comments for us, just send us an email at clearerthinkingpodcast@gmail.com. This episode was edited by Ryan Kessler and transcribed by We Amplify. Uri Bram is the podcast's factotum. If you like our show, then we'd really appreciate it if you could rate and review us wherever you get your podcasts and tell your friends about us on social media. We also hope you'll subscribe to our email newsletter called One Helpful Idea. Each week, we'll send you one idea that we think is really valuable that you can read about in just 30 seconds, along with that week's new podcast episodes, an essay by Spencer, and announcements about upcoming events. To sign up for that newsletter or to find show notes, transcripts, and more info about the show, visit podcast.clearerthinking.org.